We have a wonderful speaker today. Her name is Mary Bunn. Uh, and she is incredible, which I will describe to you all of her many accomplishments. The one thing that makes us very, very happy is that she's one of our own. She graduated from our doctoral program and has gone on to continue to do such amazing work. So we are so happy to welcome Mary back. She is an assistant professor at the University of Illinois at Chicago, or as we know, UIC, Department of Psychiatry. She is also the core faculty and co-director of the Global Mental Health Research and Training Program in the UIC Center for Global Health. She also, as a licensed clinical social worker for over 20 years, she runs a therapy clinic for refugees and asylum seekers at UI Health. Informed by all of this clinical practice experience, Mary has developed mental health programs domestically and globally. Her research focuses on the development and testing of community-based mental health prevention and care interventions for survivors of war and political violence across the migration continuum. She's going to share some of that research with us today. She currently is leading an NIMH-funded study to adapt and pilot a test and pilot test a peer-led family and social strengthening group intervention for refugee families from the Middle East for delivery in public libraries. So very interesting work. She has many publications as well. The title of her talk today is Rethinking Mental Health Care, Community-Based Mental Health Services for Forcibly Displaced Families. So please help me welcome Mary to the Davis Lectureship Series.
Great, thank you so much. Can you hear me okay? Okay. Not too loud? Okay, I'm getting a thumbs up from way in the back, so I'm assuming we're ready for takeoff. Thank you so much for that nice introduction. It's an honor and great to be back at SSA, aka Crown, or perhaps the other way around, and to share work, as Colleen talked about, that I'm doing to develop and test community-based mental health services for forcibly displaced families and communities. Much of the work I'll be discussing today is really still very much in progress, so it's a timely moment to share our work to date and have the chance to engage with you around our initial insights and outcomes. So, of course, when conducting cross-cultural, community-based early career research, it's safe to say it takes a veritable village to do that. So I want to just start by acknowledging my team at the lab I lead at UIC, which is called the Flourish Lab. And I think important for the topics of today's conversation is just to highlight that our team members really bring together diverse insider perspectives relative to the lived experience of displacement, of migration, of Middle Eastern culture, of Arabic language and dialects that's so crucial to engage in meaningful work in this area. So I want to start by, a bit of housekeeping that Keith asked me to mention is just any clarifying, urgent clarifying questions about slides, we're happy to discuss in the moment, but then I think we'll reserve time at the end for a broader discussion. So let's begin by just spending a few moments setting the context for global forced displacement. Not sure who's in the audience here in terms of these topics. So what do I mean when I say forcibly displaced individuals? So those are people who have been forced or obliged to flee or leave their home or places of residence due to war, due to human rights violations, due to natural or human-made disasters. And this can include individuals with a variety of legal statuses, refugees, asylees, as well as those without legal statuses. So present day, there are approximately 117 million individuals worldwide who are displaced, and approximately a third of these individuals are refugees. So in today's talk, you'll hear me kind of use some of these terminologies interchangeably. forcibly displaced refugees, which is a sort of certain class of forcibly displaced individuals. Sometimes when referring to such communities in the US, I prefer to use the term newcomer communities. And since we'll be talking a good amount about communities from the Middle East, I just want to highlight that the wars, particularly in Iraq and Syria, have produced the most refugees from the Middle East. And as you see this graph on the right here, which is from UNHCR, which just tells this story of kind of escalating forced displacement since 2009 up until 2023. So, of course, naturally, geopolitical conditions and U.S. political will have resulted in significant new waves of newcomer communities to the U.S., especially from Afghanistan, from Ukraine, some from Syria, et cetera. So just to give you a sense of kind of where we are in terms of overall populations. So now there's a very strong and substantial body of evidence in terms of, we can imagine, the mental health vulnerabilities that refugee newcomer communities face as a result of these intersecting life experiences. First, of course, the first point you see there on the slide are known rates of elevated exposures to diverse forms of trauma, violence, loss, ambiguous loss, and just really important to keep in mind that these experiences occur across the entire migration continuum. So in the country of origin, during resettlement, in displacement, and also in resettlement as well. And then as a result of these overlapping life adversities, research strongly indicates elevated rates of a range of mental health problems, most commonly anxiety, depression, and PTSD. Those have been the most well-documented mental health problems, but also emerging literature relative to grief phenomenon, adjustment problems, somatic symptoms, and these conditions are documented in adults, child, and adolescent populations. So an area of particular focus in my own work is really examining the broader social relational consequences of war, political violence, and forced migration. And so there's also a very strong body of literature examining how one's individual trauma or life adversities can impact the psychosocial health of others in the family, as well as intergenerational or even transgenerational impacts that can persist long after those events have subsided. Forced migration causes massive disruptions to community and social support networks that are necessary for human survival and well-being. And this includes all different kinds of things, certainly disruptions to family systems, community roles, connections and support that was previously derived and available from others. And then finally, thinking about family separation as perhaps one of the most common impacts, and which has been identified as a key risk factor for mental health problems, and which can result in relational stress within the family system, gender, generational transformations, and certainly, of course, losses to those important familial support systems. Families and communities are certainly greater than the sum of their vulnerabilities, so it's important to also acknowledge the strong evidence related to the positive health and mental health benefits of diverse social resources for refugee or forcibly displaced communities. Family has been identified as an especially important social resource, a context for deriving support, for making meaning of life experiences, for coping with the effects of war and resettlement. And research particularly conducted with communities from the Middle East has highlighted specific importance of familial networks, social group membership, and belonging as critical coping resources, and which have been linked to positive mental health outcomes. So in spite of these sort of profound mental health and psychosocial support needs and these available strengths and resources, there are currently numerous challenges to meeting what we call MHPSS needs, or mental health and psychosocial support needs. This maybe firstly and historically has included very limited funding to invest in mental health needs assessment, for dissemination and implementation of evidence-based interventions and services, and capacity strengthening efforts. Given this, there are naturally service gaps within the community, and there has been a real overinvestment, in my opinion, in research into highly specialized individual psychotherapies, where in fact, diverse models and services are needed to meet the full complement of vulnerabilities. So even when services, quality services are available, research documents numerous barriers to accessing those services, a lack of culturally appropriate models, stigma, practical barriers, and so on. And then finally, there's really been an absence of an overall, I'm talking about the US context now, an absence of an overall vision and a model for integrative mental health and psychosocial support that's really inclusive of these diverse needs and services. So to this latter point, some colleagues and I wrote a piece last year or so to begin to map out what an MHPSS framework that could include a spectrum of services from promotion to specialized care, that integrated a public health approach, that utilized and really highlighted the role of non-specialist or peer providers. And that initial work actually led to a 2-year SAMHSA-funded project that's called Reimagining Mental Health Services, and we've just wrapped phase 1 of that project. I know this is very dense. It's probably very hard to see from where you are, so don't worry. I'll walk you through the points I want you to take away from this. So we led this in collaboration with colleagues at the International Rescue Committee, an advisory team, and key informants to really rigorously and iteratively develop this framework for the US context and specific to forcibly displaced populations. So in this framework that you probably can't see at the top, what we do is we outline 5 critical service domains: safety and basic needs, community support and integration, mental health promotion and prevention, mental health treatment, and then memorialization and restorative justice, and really think about mapping those services, benefits, and supports at the individual, at the family, at the community, and then the broader policy and systems level. What's exciting about this is that we're now launching into the second phase of this project. We've had tremendous interest in this and developing a whole range of complementary tools, and then we'll be delivering this as a mental health services planning, training, and capacity strengthening intervention for MHPSS leadership and policymakers. So the other benefit of this framework is that it also really allows us to see what are the needs, what are the service needs, and where is the available evidence base. And in short, there's a need for research investments across the board. So situated within that comprehensive framework of multi-level needs and priorities, today I want to tell you about work I'm doing to address a fairly massive gap, which is in the area of mental health prevention and specifically family-based prevention. That really aims to prevent escalation of symptoms and mental health problems, and to really leverage and strengthen family relationships and supportive social and community resources. So this NIMH-funded project is a KO1 project, which is called a Career Development Award in the NIMH system. And this project really aims to address that gap by adapting an evidence-based multiple family group model called CAFES, which stands for Coffee and Family Education and Support, and aims to adapt it for use with families from the Middle East and for delivery by peer providers in community settings. What I'll tell you about is how we went about adapting the model and then testing it, especially for feasibility, acceptability, and exploring preliminary effectiveness. We're conducting this project in partnership with 2 community-based organizations. One is ICNA Relief, and the second is the Syrian Community Network, as well as, and those are organizations that have well-established relationships with Arabic-speaking communities in the Chicagoland area. We're also conducting this in partnership with the Skokie Public Library and the Chicago Public Library, and now a kind of ever-growing list of new community partners, including the Skokie Morton Grove School District 69 and another CBO called MIRA. So to conduct this study, we're using what's called a hybrid type 1, this is a mouthful, implementation effectiveness randomized pilot trial design. So that really primarily focuses on exploring implementation outcomes, especially, as I mentioned, feasibility, acceptability, fidelity, and also exploring our theorized mechanisms of change. And then just sort of preliminarily, we're not powered to really detect clinical change, but preliminarily looking at changes across a range of outcomes that I'll tell you about: mental health, family level outcomes, and community level outcomes. And then if you can see that from here on the left side of this model, you'll see that we're using what's called the EPIS framework, which is an implementation science framework. It stands for exploration, preparation, implementation, and sustainment. And this is what they call a process and determinants model. That's well suited to the aims of this study, since it really can guide the full extent of the research project from adaptation to pilot trial, and with a real focus on looking at both inner context variables and outer context variables. Okay. So today, again, this is very much a study in progress. We have completed aim 1 of our study, which was adaptation of the model, and we've launched our pilot trial. So I'm going to spend most of my time telling you about the adaptation phase of the project and update you on where we are with our pilot trial and just some initial outcomes. So we're at University of Chicago. I should spend a little bit of time setting the conceptual and theoretical context for our cafes intervention and for this project. And so just to say, my own work, actually much of my own practice and MHPSS leadership work has been spent in and with communities from the Middle East. But my own specific work with Syrian families began approximately 10 years ago as part of my dissertation work, conducting research in Jordan, and specifically really aiming to look at the social relational consequences of war, which are so common but generally under-theorized and under-addressed in the literature, and how they interplay with mental health. So through that research, we developed a process model that we call ambiguous loss of home, and which you see here. And in that model, home is really is considered as a multidimensional concept that incorporates the physical geography of landscapes, constructed spaces, cultural identity, place-based experiences of belonging, familial, social, religious, occupational networks, as well as feelings of support and safety that are tied to a familiar home place. So in our model, we theorized 4 dimensions of ambiguous loss of home that result from war, political terror, and forced displacement. And those included ambiguous loss of safety, social connections and identities, and connection to place and dreams and imagined futures. And also to kind of capture this cyclical process that we found Syrian families engaging in of both losing and remaking a sense of home and displacement. So I raise that here because really the findings from that study, for me, really underscored the need for evidence-based interventions that really attend more squarely to the social relational losses that can be equally challenging to one's adjustment, to one's mental health. And in terms of interventions, what the findings really suggested to us was that the need for interventions that really strengthen social connections and support, and in situ interventions, those that are conducted in schools and community settings, in mosques, to really increase access to evidence-based services, and which can continue to serve as a vitalizing source of support for refugees over the long term. So that's an important backdrop of this NIMH study. And since we're really thinking through a prevention lens, as I mentioned, we're also really drawing on both family and community resilience theory, which focuses on family and community protective processes that can really be harnessed and strengthened to ameliorate hardships and enable healing. Prior to this KO1 study, I received 2 years of private foundation funding to conduct formative research with caregivers and youth from refugee families from the Middle East here in Chicagoland, and also service providers and the purpose of those interviews and those focus groups and those consultations were to explore life experiences, needs, strengths, help-seeking preferences. And that research, which I'm happy to discuss more in the Q&A, there's a great deal to get through aside from that. But just I want to highlight kind of two main areas of important findings that help us set a context for cafes. One is multi-level and interrelated needs and problems. That certainly reflects what we know from the literature in terms of access to basic services and security, community level concerns, family support networks being impacted, struggles with peer relationships, for example, for adolescents, and challenges in parent-child relationships. And then in terms of, we also really inquired about the kinds of services and supports that people thought were needed and would be helpful and preferable. And there were three kind of determinants that came out of those interviews. One had to do with what participants called groups of families. So this idea that families would benefit from gathering together with others to share experience. Second, related to peers or engaging people with others with shared lived experience and shared wisdom from that experience who could deliver services and support families. And then third had to do with the timing of intervention. So a preference for the early phases of resettlement, which we sort of operationalize as the first few years, when needs are great, but often when formal services drop off for refugees. So that really led us, to that, and then a systematic review we did of family-based mental health interventions for refugee communities led us to identify the multiple family group model as one that was potentially really well suited to the needs of families that we were working with. And these interventions, which have been used with all kinds of different families and family systems, but in terms of refugee or forcibly displaced communities, they bring together family members from multiple different families who are experiencing similar culturally mediated stressors. And these typically involve families where there's at least one member, either a child or an adult, who's experiencing some degree of mental health distress. And to date, they've been delivered in community and school settings. So we specifically selected cafes, coffee and family education and support, as a prevention model that could be adapted to meet the needs of families we were concerned with. And this model was originally developed, I think it was originally developed at UIC, and originally developed for African American families in Chicago, and then adapted by my colleague, Dr. Steve Wine, for use with Bosnian and Kosovar refugee families in the early 2000s. And the model that was originally tested really included components that targeted family level processes, family communication, family goal setting, identification of family strengths, and those all really resonated with what we had identified and seen through our interviews. But the original model was really intended as what they call an access and referral intervention. So their ultimate outcomes were increased knowledge of mental health and access and utilization of formal mental health services. So based on our formative work, we really saw a need to really bolster this intervention and add new components that you see circled in red, if you can see that from where you are. And that would really allow us to target more directly mental health symptoms and distress that children and family and parents were experiencing, and to promote emotion regulation skills, and then also especially leverage that group setting as a way of really strengthening potential social connection and support through the network of families who participated. So we conducted an initial adaptation of cafes based on that formative work, and that was sort of the model that we entered into the adaptation process with. So adaptation is a key concept in implementation science that's defined as a process of thoughtful and deliberate alteration to the design or delivery of an intervention with a goal of improving fit for a given context or community. So there are many, many different adaptation frameworks in implementation science, but they share many similarities in terms of moving in this very deliberate and stepwise fashion, beginning with exploration of need, exploration of the fit of existing models, making changes in consultation with diverse partners and inputs, and then pilot testing, and then ultimately engaging in research to sustain the model. So for our study, we utilize the adapted framework, which is one of these such adaptation frameworks. And we have also drawn on human-centered design practices during our adaptation. So human-centered design is a process that reflects a set of practices that involve the development of products, technologies, and other artifacts for direct human use. Human-centered design is really characterized by the requirement that the human perspective is considered from the initial conception to the eventual design, and that the people who will use or be affected by the design product are very much involved in the process. Radical idea, right? So in many ways, the design practice that you see here resembles adaptation processes in implementation science, with an exploratory phase where you see the aperture opened wide as you kind of consider needs and possibilities, and then closing the aperture as key innovations or services become clear. And then as you see in this double diamond graphic, reopening the aperture to think about needs of users vis-a-vis the service, and then closing down as those decisions are made. So human-centered design and design practices have been gaining traction in healthcare for some time, and they're beginning to emerge in mental health care as a useful tool for adaptation, with a focus especially on maximizing ease of use and meeting the needs of target users and enhancing understanding of the implementation context. And this can be especially useful in the context of services for refugee communities, where there are often diverse degrees of literacy, and in contexts where you might be utilizing non-specialists or peer providers. And so you really want to think about how can we set our tools up in such a way that they can be readily used. So in this project, we especially drew on participatory design, which is a kind of subfield that focuses especially on robust collaboration and consultation with communities to develop social innovations, and with even more of a focus on robust collaboration and shared power and ownership. So for our adaptation process, we combined human-centered design practices and adaptation methods, specifically of the adapted model, to create this kind of inclusive and participatory process. And that took place over the course of about a year. And we identified a 5-phase process of participant engagement, concept exploration, concept refinement, and then concept finalization and production that structured this process. So participant engagement really involved inviting people into the process and specifically convening our co-design teams. I'll tell you a bit more about that. During concept exploration, that involved workshops and key informant interviews that really aimed at exploring this whole idea of the suitability of this multiple family group model. Like, is this going to work? What's going to be a challenge? What's going to be received well? Phase 2, which we called concept refinement, really involved research that really dug into the intervention components, the activities, the homework. During concept finalization, we worked to define the program identity, outreach and recruitment strategies, peer qualifications, and then finally moved into a production phase for the facilitator's handbook and participant tools. So a real centerpiece of that process involved convening 2 co-design teams with diverse lived experience that was important for the project. So this included first a family co-design team, and those were dyads of caregivers and youth from newcomer families from the Middle East. And since this was a multiple family group model, it was intended for both youth and caregivers. It was very important to involve those voices in the adaptation process. And the team also really enabled us to kind of simulate different aspects of the program and to elicit issues and test out different features of the program in a kind of multiple family group setting that was our co-design team. We also partnered specifically with community-based organizations in this project, or we have. And community-based organizations really provide vital services in the kind of broader ecology of services for refugees. But they're very rarely included in the development and testing of evidence-based interventions. So our second co-design team involves staff from these CBOs, many of whom also had navigated forced displacement and resettlement themselves. So as we entered into this adaptation process, we mapped out different areas that would be the focus of our adaptation and redesign. So this naturally included the content of the model, but also outreach and recruitment, and engagement strategies, delivery agents, delivery setting, and then also thinking about the broader system and policy context, really with an eye from even this very early phase, as much as we could, trying to structure the program for long-term sustainment. So during this full course of adaptation, we utilized a range of different methods to elicit feedback into the cafe's model. And you see here those included, so those were individual youth and parent interviews, family interviews, co-design workshops, community practitioner interviews, process and artifact documentation, service setting observations, and also visual design research looking at key symbols, fonts, color, and their significance for the communities that we were really seeking to work with. So across these methods, we utilized a range of different design tools to facilitate our adaptation process. And here is where, at this stage of the process, knowing what I do about implementation science and design methods, here is where I think design methods really makes itself stand out and well known. And that is the production of these objects, these artifacts, what they call sometimes prototypes in design methods, which draw attention to different parts of the intervention. Also, for us, this included like reflection exercises that we had our co-design team members engage in that allowed them to kind of get into the mindset that would be suitable for giving feedback on the model. So I'll highlight maybe just the first one on the left there that we developed, and this was really at the beginning phases of our adaptation, and that's called a journey map. Maybe some of you have heard of this before. So it's massive. I mean, we rolled this thing into our workshops, and what it is really a step-by-step visual representation of the multiple family group model and all the steps that would be involved in participating. And we use this as a tool in co-design workshops and our individual key informant interviews that ran concurrent to this process. And we asked participants, we gave it to them ahead of time. During the interviews and workshops, we asked them to interact with the map and respond, of course, with sticky notes, because lots of sticky notes in design practices, but to really capture what they thought would work well and what would be challenging or what would need to be addressed and modified. So I've come to learn that there's a kind of a rule or a norm in design that you really don't ask people to offer feedback on something that they have not experienced. And so really the idea is that these artifacts and these provisional prototypes, they offer participants an experiential interaction with the innovation or the service or the innovation. And in doing so, the idea is that you really yield higher quality, higher fidelity feedback into the areas that you're most interested in. So that process resulted in a model to move forward with, which we now call Cafes 2. So that includes the adapted model includes an initial home visit, and then 6 multiple family group meetings, and our co-design processes and our data collection led to modification of a range of different program elements, and really with the goal of better engaging families, meeting their needs, and again, thinking of how could we structure this so it might have legs long-term for sustainment. So I'm gonna, you'll mostly just have to listen. I think at this point, this is probably pretty hard to see there. I'm going to talk to you about maybe two of the areas. So this slide that you see here, which references that earlier bullseye, really captures the findings from this adaptation process, and it highlights kind of core themes that arose, and summarizes how we approached and responded with adaptations. And we've used these dotted lines with bullets because oftentimes we found that the findings had implications for multiple domains of the intervention, not only the content, but the way we train peer facilitators, or I'll highlight that in my next slide. So for today, I want to just focus on maybe two of these key findings. So as our adaptation process unfolded, a key objective related to this idea of looking for opportunities to extend the benefits of the intervention, and to allow the benefits to be diffused and sustained over time. So relative to this, one theme that came up, which you see, you might see circled on the bottom, is called family interaction by design. And through this process, our participants really emphasized the need for a program that could be seen as fun. And we knew this was especially important for engaging adolescents in the program. And thus, the family-focused components in the intervention were redesigned to include interactive activities that engaged families in different creative storytelling processes, and which really, we hoped, allowed for bonding, family closeness, and connection during the intervention. But we also designed all of the family components to be able to be brought back home and shared with other members of the family, so that they could benefit from the program even if they were not able to be physically present. Because we anticipated, and this came up repeatedly through our process, that there would particularly be challenges for example, fathers or male caregivers to attend the program. So we try to think outside the box in terms of how could we bring the benefits to fathers or family or grandparents even, or extended kin, even if they weren't there. The second area on the top there